And thank you all for showing up this afternoon in Liberia, and to my colleagues in the US this morning. I'm going to be speaking today about specifically potentially curable breast cancer. This is a fairly basic talk, but I think it's an important talk because before we think about treatment, we need to make sure that we're staging patients appropriately and that we're using best evidence treatment pathways. And we're going to walk through some examples at the end. I'm going to start talking about how we look at breast cancer spread and staging to begin with. I think this will last about maybe 40 minutes, so there should be time for questions at the end, but if there are burning questions, jump in at any time. Here we go. In terms of learning objectives for this talk, the first thing I want to convey is some of the basics of breast cancer spread, which helps inform how we subsequently stage patients. I want to talk a little bit about both the why we stage breast cancer and other cancers for that matter, and how we actually accomplish this. And then I want to switch gears a little bit and talk specifically about potentially curable breast cancer, early and locally advanced breast cancer, and go through a couple of staging examples and then walk you through clinical pathways. So let's start with some of the basics. I know this is very simplistic, but again, I think it's important to review it to just kind of get it in our heads before we move forward. In a very simplistic way, normal cells can become abnormal. Those abnormal cells can multiply in an unregulated way and become a cancer. And then ultimately, that cancer can spread either locally or it can enter lymphatic vessels and spread to lymph nodes in the regional lymph node basins, or it can penetrate blood vessels and migrate to virtually anywhere in the body and set up camp as metastatic disease. When we talk about breast cancer progression, again, the three different elements of progression include local spread within the breast, spread to regional lymph nodes, and distant spread to other organs. So let's look at each one of these. As I said, a primary tumor forms and then it invades locally. As it progresses, it can invade in the setting of a breast cancer. It can involve the skin and the fascia when it becomes more advanced. It can also penetrate the chest wall musculature. And finally, it can spread to other parts of the breast as it becomes more locally advanced. In terms of the nodal tumor spread component, again, specifically for breast cancer, it tends to spread in a somewhat orderly fashion, although not always. The first place that we look for spread from a breast cancer is to the axillary lymph nodes in the armpit area, to the supraclavicular lymph nodes around the collarbone, and sometimes the infraclavicular area as well. And then in some circumstances, it can also spread to the internal mammary chain of lymph nodes, which is primarily occurs with medial lesions in the right and left breast. And that's the vertical green group of lymph nodes just adjacent to the sternum that you can see here as well. In terms of thinking about how breast cancer spreads to distant metastatic sites, I think you all understand that breast cancer can spread to virtually any part of the body, although there are certain places that it tends to spread preferentially, including the brain, the lungs, the liver, and the bones. I'm sorry, the bones and then the liver. And it's important when we're thinking about looking for metastatic disease that we focus on these four different areas, although recognize that it can also spread to, again, virtually anywhere in the body. So let's talk a little bit about why we stage breast cancer and how we actually accomplish staging breast cancer. So let's go over some of the basics. Why do we stage? We stage because by determining a stage, it helps us determine an appropriate treatment plan. And we're going to talk a little bit more about this when we get to treatment pathways for curable breast cancer. And again, I think it's important to recognize that what we're talking about here really applies to virtually any cancer. Staging also is crucial in helping us determine a new patient's prognosis. So a patient that presents with an early stage breast cancer, like a stage 1 breast cancer, is going to have a very different prognosis than a patient with metastatic disease. So that's really important when we're communicating to patients what their long-term outlook is and whether or not they actually have a curable breast cancer. Staging also helps us evaluate treatments for patients with the same cancer. So if you're using a treatment for a stage 2, you want to compare it with other patients with a stage 2 cancer. The results may be very, very different if you compare patients from different stage groupings. And then finally, staging is critical when we're doing clinical cancer research. So if we're looking at a new therapy, we're trying to compare patients, it's important that you're looking at similar patients of similar stages. So I mentioned before that breast cancer stage correlates closely with prognosis in an inverse fashion. So as the stage increases, the prognosis decreases. That's not unexpected, but it's fairly dramatic in breast cancer and with many other cancers as well. For localized disease, the 5-year survival rate is very high. As you include patients with regional lymph node involvement, it decreases, and then it really falls off when you're talking about patients with distant metastatic disease. So let's talk a little bit about how we actually stage cancer patients. So stage is applied to cancers that are alike in site and histology. So you're gonna do a different staging for a patient with a rectal cancer than a breast cancer. Staging may be different even within a certain site if the histology is different. So you may stage a breast sarcoma differently than another type of breast cancer. Cancer staging groups cancer cases into broad categories and classifies both the local extent of cancer spread and spread beyond the primary tumor to either lymph nodes or metastatic sites. And we're going to talk a lot about this, but when we're staging patients, for most cancers, we use what's known as the TNM system, which is based on 3 components: tumor, or the T stage, lymph nodes, or the N stage, and metastasis, or the M stage. And what we do when we see a new patient is one of the first things we do is to open the Cancer Staging Atlas to actually look at the particulars for each cancer. Say if it's a breast cancer, we want to designate a T stage, and that specifies what you're looking for each particular stage. It looks at the size, the extent, and depth of penetration of that local primary tumor. It also gives us guidance in terms of how we stage the lymph nodes. And specifically, it's usually looking at the presence or absence of tumor in the regional lymph nodes. And I underline the word regional because when we're talking about regional lymph nodes, we're talking about the lymph node basin where tumors spread to for each individual cancer that we're staging. It also sometimes specifies the number of lymph nodes or the clinical appearance of those lymph nodes. And then finally, the M stage, or metastasis. This stage looks at the presence or absence of distant spread to other organs, and sometimes it subclassifies things from there. So this is really, do you have metastasis or don't you have metastasis? So what are some of the challenges that we face when we're staging patients? This first one here, that recommended staging studies are not always available, certainly applies to Liberia and actually most countries in sub-Saharan Africa and in other parts of the world. What we have available in high-resource countries in Europe and the US may look very different than what you have in Liberia. And it's important to remember that even though studies are recommended in the staging manual, often you may not have those available, and you do the best that you can based on what is available. The other thing that's important to understand is that there can be conflicting information about the location of a primary tumor. And this comes up in certain sites, especially with more advanced tumors. For instance, if a patient presents with a head and neck tumor that involves, say, the oropharynx and the oral cavity, it's sometimes difficult to figure out which of these sites it's actually arising from, and you just have to use, the best available information sometimes to guess, because there may not be any way to clearly distinguish that. Tumor size is also something that, although you may have some objective information, it may not be particularly accurate. Certainly when we feel on palpation a breast tumor, it may under or overestimate the size of the tumor. And you may have situations where there may be conflicting information about the extent of cancer spread. It may look like there's metastatic disease, but in fact that may not be metastatic disease at all. And we see this all the time with small lung lesions in patients with breast cancer, where it may be a granuloma or some benign process and not cancer. So the other thing that's a challenge is that there are rare situations where complete staging is not possible, and where we have to pretty much immediately jump in and initiate treatment in order to save a life. This situation comes up occasionally for patients with advanced thoracic tumors causing superior vena cava compression, where sometimes you may be forced to treat without all the information that you would like. Obviously, that's preferable in a life-threatening situation. So again, we do the best that we can. It's not always perfect, but we do our best to get it done. And sometimes it may take a while, and we may even need to initiate therapy if we're forced to. One concept that I think is important and a little bit confusing for people who are just getting familiar with staging systems is that we talk about clinical stage, and then we talk about pathologic stage. So clinical stage is the stage that you give a patient at the time of the initial diagnosis. That patient is assigned a clinical stage. It's not based on a big surgical procedure. So for instance, a patient presents with an early breast cancer, you do your biopsy, you do your studies, you assign a clinical stage. Then that patient may go on and have an excision of that breast cancer and lymph node sampling, or may have a mastectomy. And the pathologist studies that tissue that's removed and assigns it what we call a pathologic stage. That pathologic stage is actually usually more accurate than the clinical stage, because you're able to get a lot more information from the pathology. And that can be very important in terms of guiding next steps as well. So if a patient's staged and then treated, and then years go by and the cancer recurs, the patient at that point is considered to have recurrent disease. It's important to remember that the initial stage remains the same. So if a patient presented initially with a stage 1 breast cancer, they're always going to have a stage 1 breast cancer. That is their initial stage. If it's a recurrent cancer years down the line, say in the liver or the lungs, we would say that patient has recurrent and metastatic disease. We wouldn't say that patient has stage 4 disease and, we may do studies, but in terms of categorizing that patient has recurrent disease and initially had a stage 1 breast cancer. So a patient presents to us with a newly diagnosed biopsy confirming a breast cancer. What's next? Well, I just said, really the first thing you do after you inform the patient that it's a breast cancer is to do staging studies. So let's look at the flow diagram here of breast cancer staging. So as I said, a patient presents with a breast cancer. You define the primary site and you obtain a pathologic diagnosis. Then you go to your staging manuals and you look it up in the staging manual to see what studies are needed. Then you go ahead and you perform this important staging evaluation to determine if it's localized disease, which is potentially curable, or whether it is metastatic disease, which the patient may also be a candidate for treatment, but it may not be curable disease. In terms of those staging studies, those can include things like physical exam, imaging, laboratory studies, and also surgical staging in some cases. From that information, we determine a cancer stage, and that cancer stage, as we'll discuss in a minute, determines the subsequent clinical pathway and gives us a very important prognostic information as well. So how do we determine breast cancer stage? Well, assessment begins with a complete physical exam. And as I said, it can include imaging, laboratory tests, and pathologic studies. And it's really only after the staging is complete, except in those rare emergency situations, that the team can make a formal treatment plan and discuss it with the patient. So in terms of staging workup, the first piece, which is very important, is a history and physical exam. That includes not only a complete physical exam, but a close assessment of both breasts, of regional lymph nodes, neck lymph nodes, also assessment of metastatic sites. So if a patient comes with a breast cancer and is complaining of really severe pain in the back or the hip, that warrants additional evaluation. Certainly, you'd want to listen to the lungs, you'd want to palpate the liver, make sure there's no evidence of hepatomegaly, things like that. And then you'd want to do a complete blood count, liver function tests, alkaline phosphatase. If it's available, you'd like to get mammograms. Sometimes you do an ultrasound. And then other imaging may be indicated as well. As a minimum, in a resource poor setting, we favor a chest X-ray and abdominal ultrasound, certainly for patients with more locally advanced disease. As I said, bone X-rays, if there's any question about bone metastasis. In a high-resource country, and you'll see this in the staging manuals, there are certainly situations where we might consider CT scans or various nuclear medicine scans like a bone scan or a PET scan. Although unfortunately, the availability of that in your setting is, I'm sure, extremely limited. And I'm quite certain that nuclear medicine scans like bone scans and PET scans aren't available at all. The imaging is really useful in helping us assess for metastatic disease or stage 4 disease. As I said at the beginning of the talk, there are certain sites where breast cancer preferentially spreads, like the lungs, the liver, the brain, the bones. And these are just a few images of some of the metastatic foci that you might pick up on imaging. This is a proximal humerus lytic destructive lesion. It's very obvious here in this heavily involved proximal humerus that looks at risk for fracture. Certainly, having cross-sectional imaging available is very useful in trying to pick up liver nodules consistent with metastatic disease, similar to what you see here in this patient with breast cancer with widely metastatic liver involvement. Certainly a CT scan is preferable, but even on a plain chest X-ray, you can see lung nodules, and certainly brain metastasis really require cross-sectional imaging, either CT or MRI, to define them if they are in fact present. So we talked at the beginning about the TNM staging. Just to review, T stage is the primary tumor within the breast. And for breast cancer, there are subcategorizations, but in general terms, for clinical staging, a tumor less than 2 centimeters is a T1, 2 to 5 is a T2, greater than 5 centimeters, a T3 lesion, and a T4 lesion is skin or chest wall involvement. And when you look in the manual, as I said, you'll see some subcategorization of each of these T stages. For lymph nodes, N0 means no lymph node metastasis, N1 is kind of early axillary lymph node metastasis, N2 more advanced, and N3 generally involvement of areas like the supraclavicular lymph nodes or axillary and internal mammary lymph nodes. And M0 is the easy one. Basically, M0 is no distant metastasis, and M1 is distant metastasis present. So once we get our T, our N, and our M clinical stages, that information you can look at in the tables, and you can come up with what we call an overall clinical stage. That goes from 0, which is kind of a pre-invasive or in situ cancer, or stage 1, 2, and 3 disease, which we would consider early invasive cancer and locally advanced cancer. And then stage 4 includes anybody with M1 disease or metastatic disease. It's important to also recognize that while we talk about TNM staging, others might use a non-TNM clinical breast cancer staging and break things down into early stage, locally advanced disease, and metastatic disease. Whenever possible, we certainly would favor using the TNM system just because it gives so much more information than a non-TNM staging. So we're going to talk next, we're going to switch gears and talk a little bit about curative breast cancer. And for curative breast cancer, we're talking about early and locally advanced breast cancer. For potentially curable breast cancer, generally, we're talking about patients with no metastasis. There are some situations where patients with very minimal solitary metastasis potentially can achieve long-term survival. But for the sake of this discussion, we'll talk about potentially curable breast cancer as patients with M0 disease. I think it's important at this point just to emphasize something that I think all of you know, that it's really essential to educate women about routine breast care and make breast exams available at health centers. We know that patients with early breast cancer are curable and that patients with metastatic disease are not. So breast cancer is curable really only if it's detected when the disease is confined to the breast and regional lymph nodes. Once it's gone to the bones or the liver, it's treatable, but probably not curable. And generally, curable disease occurs when all obvious disease in the breast and axilla can also be surgically removed at some point in the treatment pathway. So again, coming back to patients with curable, potentially curable disease, it's the early stage disease and the locally advanced disease, although the locally advanced disease patients have a worse prognosis. And what we're talking about, again, is patients with stage 0 through stage 3 disease, looking at our TNM clinical staging chart. So treatment plan depends on stage. For early and locally advanced cancers, we're talking about a goal of cure, eradicating the disease and reducing the risk of subsequent recurrence, both within the breast and in other parts of the body. The primary treatment is really the local treatment, and that includes surgery, sometimes in combination with radiotherapy, and rarely with radiotherapy alone as a primary treatment for patients who are unresectable. And then we're also talking about what we call adjuvant treatment or systemic therapy, which reduces the risk of recurrence. And I know Rami's going to speak to this in the following talk, but we're talking about various hormonal therapies, different chemotherapies, or what we call targeted therapies like Herceptin, anti-HER2 therapies. For the sake of this talk, we're not really focusing on treatment of metastatic disease, that is stage 4 disease, where the goal is really palliation to try to prolong survival, alleviate symptoms, and preserve the quality of life. And the primary treatment for that is systemic therapy, although there may be some roles for palliation with either radiation or surgery in some select cases. So just as an overview of breast cancer treatment for potentially curable disease, early stage disease, generally we're talking about surgery being done first, either mastectomy and axillary dissection, or in places where radiotherapy is available, breast conservation therapy. And then for most patients, but not all patients, systemic therapy follows the primary local therapy. For locally advanced cancers, the treatment paradigm is a little bit different. Usually, we would consider systemic therapy first as what we call neoadjuvant treatment to shrink the cancer prior to surgery, which will follow, and sometimes radiotherapy after the surgery for locally advanced disease after a mastectomy. So breast cancer management certainly depends on what diagnostic and therapeutic modalities are available. And certainly the modalities that may be available in Liberia look very different than what we have in the US. So we have to treat patients based on the resources available. And those resources that may or may not be available include various imaging and laboratory tests, different drug therapies, which you may have some, but not all of the drugs that we might use in the US or elsewhere for treatment of breast cancer. You may or may not have the surgical expertise. You may not have surgeons who are able to do big reconstructions. And then you may or may not have radiotherapy. And my sense is in Liberia, to get radiotherapy, you need to go out of country. So how we treat a patient in Liberia has to be based on the resources that you have available for treatment. One thing that I think you all recognize, but I really have to emphasize, is that delays in getting breast cancer patients to treatment need to be minimized, because we know that delays in treatment of breast cancer have been linked with increased mortality. Patients do better when they're diagnosed earlier and they get on to treatment sooner. And there are all sorts of places along the treatment pathway where things can get messed up and patients can take too long to get to treatment. But I think as soon as a patient is seen in a breast center and is found to have a breast lump, the clock starts ticking. You need to get that patient evaluated. If they require a biopsy, you need the biopsy done to confirm the cancer. You need to get the staging done, and you need to get the therapy coordinated. Generally, in patients who don't get neoadjuvant chemotherapy, we like to get surgery going within 90 days of diagnosis and chemotherapy going within 4 months of diagnosis. So let's walk through 2 breast cancer cases where we're going to go through an early case and a more locally advanced case. And we're going to talk not only about staging, but then using that staging information to go through clinical treatment pathways. For localized disease, again, we're talking about early breast cancer. And specifically, we're going to be focusing on stage 1 and stage 2A disease for early breast cancer. Stage 0 is also, you could call it an early breast cancer, but it's really an in situ breast cancer. And the management might look a little bit differently. My guess is without advanced screening techniques, you're not going to see too many patients presenting with in situ disease. Early stage breast cancer, again, means that the tumor is 2 centimeters or less, it hasn't spread to more than a few lymph nodes, or that it's a little bit larger, less than 5 centimeters, with no evidence of any nodal spread. So case 1, this is a 37-year-old healthy premenopausal female who presents to a clinic with a non-tender 3-centimeter non-fixed mass in the right upper outer quadrant. On close exam, the breast skin is normal. There are no palpable axillary lymph nodes, and the remainder of the physical exam is normal. In this case, minimal staging was necessary, other than some simple blood work and x-rays. A needle biopsy was subsequently done under ultrasound guidance and confirmed what we would call a moderately differentiated infiltrating duct carcinoma, a grade 2 cancer. Estrogen receptor was done and was positive. Unfortunately, HER2 testing was not available in this setting, so it's considered unknown. So in terms of staging, as I said, it was a 3-centimeter non-fixed mass. So this patient has a T2 primary tumor and has N0 disease. There's no evidence of lymph node metastasis clinically. It doesn't mean that at the time of surgery, where there's pathologic staging, that there might not turn up, it might not turn up some axillary lymph node involvement, but right now we're going under the clinical stage of T2N0. So a T2N0 M0 cancer, the overall clinical stage based on our clinical staging tables is 2A disease, which falls within that early stage cancer. So let's look at clinical treatment pathways next to guide subsequent treatment. So staging has been completed, and at this point we use evidence-based clinical guidelines to determine the clinical pathway for this patient's breast cancer management. And evidence-based clinical guidelines really inform how a breast cancer is best treated. Do we use surgery? Do we use radiation? Do we use hormonal therapy or chemotherapy or targeted therapy? The guidelines help guide how we manage a particular patient, so we're not just kind of winging it and making it up as we go. The one thing that's an incredible resource is something called the NCCN guidelines, the National Comprehensive Cancer Network guidelines, which provide us with clear pathways for management based on best evidence. In addition, they've done additional pathways specifically for places around the world where they don't have the resources that we do in the US. And again, those resources can include surgical expertise, radiotherapy, drugs, all sorts of pathologic testing. So these are really helpful. And we're going to walk through some examples in the 2 cases we're presenting. So as I said before, this looks very busy, but we have a T2N0 M0 stage 2A non-metastatic M0 invasive breast cancer. That's, if you look at the left-hand side under diagnosis, that's the clinical diagnosis right now. We've already done our workup, and as you move to the right, we've done our history and physical, we've done imaging that's available, we've done pathology review. The grayed out areas are things that we would consider in a high resource country, but aren't available in places like Liberia. We did determine tumor estrogen receptor status, although HER2 status was not available. And given that this is a woman of childbearing age, we would want to speak with that person at this point about her fertility and sexual health concerns, and also ensure that she's not pregnant at this point with a pregnancy test. And we would also want to assess for, her psychological distress and try to provide services for her as needed. So this woman, as I said, has a T2N0M0 breast cancer. In this case, she doesn't clearly meet our criteria for giving upfront chemotherapy. So we would consider her for local regional treatment, and we follow our clinical pathway, as you can see here. In terms of local regional treatment, you could consider either breast conservation therapy, including wide excision, lymph node sampling, and radiotherapy. But if you don't have radiotherapy, like you don't have available in Liberia, we would consider this patient for a mastectomy at that point.
It looks like there's a question. Someone has their hand
Oh, I'm
raised.
sorry. Go ahead.
It says Dr. M2. Do you have a question? All right.
We can come back. We're going to have plenty of time at the end as well to answer some questions. So this patient with a clinical stage T2N0M0 estrogen receptor positive cancer undergoes a mastectomy with surgical axillary staging. And you can see that on the left-hand side of this slide. And that is given what we call a category 1 recommendation, which is a high recommendation. There's a lot of evidence that backs up that treatment plan. Subsequently, the pathology comes back and the lymph nodes in this case are not involved. The tumor is less than 5 centimeters and the margins are clear, meaning that they're well beyond a millimeter. So that patient does not get radiotherapy, which is a good thing because radiotherapy isn't easily available in Liberia. And then from there, we go on to whether the patient requires any systemic therapy. And in this case, again, the histology was a infiltrating ductal cancer. It's estrogen receptor positive, but the HER2 status is unknown. So that patient would be a candidate for systemic adjuvant treatment for this hormone receptor positive patient. I'm not going to go through the systemic therapy because that's going to be included, I imagine, in the next lecture. But that's how we walk through, the management of a patient with an early breast cancer. So let's do another case. This is a locally advanced breast cancer case. And again, locally advanced patients are those with 2B or stage 3 A, B, and C cancers. Those are locally advanced lesions where the tumor is quite large and the cancer may have spread to the skin or penetrated the chest wall musculature, and there's more extensive lymph node involvement. So in this second case, we have a locally advanced breast cancer. And in this case, we have a 55-year-old healthy postmenopausal woman with a 6 centimeter palpable mass in the right upper outer quadrant. It is not fixed to the chest wall. And there are multiple enlarged and matted axillary lymph nodes. There are no breast skin changes. And the remainder of the physical exam is entirely normal. The patient has no bone pain, no hepatomegaly, things like that. A needle biopsy is done, and this confirms a higher grade tumor. It's a poorly differentiated infiltrating duct carcinoma. The estrogen receptor was negative, and HER2 testing, again, is unavailable in this location. The patient did not have access to CAT scans, but radiologic evaluation, including chest X-ray and abdominal ultrasound, were done, as well as some laboratory tests, and they were negative for any evidence of metastasis. So this patient, with her large tumor, 6 centimeters, has a T3 tumor. The tumor did not extend to the chest wall or involve the skin, so it's not a T4 tumor. But the patient had fairly extensive matted fixed lymph nodes. This patient has T3, N2, M0 disease. So the overall clinical stage would be a stage 3A disease for this woman with a locally advanced breast cancer. Let's go back to our clinical guidelines. Specifically for this patient, again, while this patient has a more advanced cancer, it still is felt to be non-metastatic. We go through the appropriate workup specified here, most of which we've already done. And then that patient, again, has T3, N2, M0 clinical stage disease. In contrast to the first patient, this patient does fit some criteria for preoperative systemic therapy. And specifically, when you look at the guidelines, it specifies patients with bulky or matted N2 axillary lymph nodes, which this patient has. And she's healthy and a good candidate for chemotherapy, has a big lesion as a primary. So in this patient, she does get preoperative systemic therapy. Before that's done, sometimes if it's available, we might consider a percutaneous biopsy under ultrasound guidance. If that's not available, it's not available. We've already done a comprehensive metabolic panel. As I said, we did some blood tests to look for metastatic disease, because as this patient is showing us that she has more advanced disease, there's a higher risk that she may have disease in other parts of the body as well. And we want to make sure that we've ruled that out before we proceed with aggressive local therapy. So this patient is getting preoperative systemic chemotherapy. And then after that's completed, and before we would consider local regional treatment, we would do a close assessment of our comprehensive assessment to look at what type of response she has and to allow the surgeon to determine whether the patient is operable or not. And in fact, this patient had an excellent response. The primary tumor shrunk down, the lymph nodes virtually disappeared, and the surgeon feels that she can have a mastectomy at this point. Again, there are some situations, even with locally advanced disease, where you could consider breast conservation therapy, but without radiotherapy, we wouldn't follow that path. So this patient undergoes mastectomy and surgical axillary staging. And then at that point, the question is, do you do adjuvant systemic therapy? And do you do adjuvant chest wall and nodal radiotherapy if it's available? If it's not available, it's not available, even though there might be some benefit. In terms of adjuvant systemic therapy, for this patient who has an unknown HER2 status, the recommendation is for close follow-up at that point, treatments completed. The staging, the clinical pathways in the NCCN also give us information about how to follow patients after they've completed their cancer therapy. And this is critical. You're following up patients not only for breast cancer recurrence down the road, but you're also following up for any potential toxicity of the therapy that you've given. For patients who have received hormonal therapy as part of their treatment plan, generally, we evaluate patients every 3 months or even sometimes more often as needed. And we assess and encourage medication adherence, as these patients are often on hormonal therapy for years. And then we monitor and treat for any toxicities that come up. For patients like the ones we just presented who have received curative therapy, including systemic chemotherapy, generally clinical evaluation of these patients in follow-up every 3 months in year 1, every 4 months in year 2, every 6 months in year 3, and probably annually after that, in some cases more frequently. And blood work and imaging are obtained as they're clinically indicated. So that really, actually one last piece in terms of the follow-up of these patients. I think it's important to remember that once a patient has completed therapy, there are some things that our patients can modify in terms of maintaining an active lifestyle and a healthy diet, limiting alcohol intake, and maintaining an ideal body weight. All of those things actually are important because they can optimize subsequent breast cancer outcomes for these patients. So it's not just the follow-up for recurrence and looking for toxicity, but it's having that ongoing conversation with the patient about ways that they can take charge and optimize their outcome as well. So just to summarize, as we kind of come to a close here, cancer staging should always follow biopsy confirmation of a new breast cancer or after biopsy confirmation of any cancer for that matter. Staging's a really key component of cancer care, and it's really crucial in determining an appropriate treatment plan, as we just saw. Staging helps us determine the prognosis of a new cancer patient. And once a cancer stage is determined, we can define the appropriate clinical treatment pathway using the best evidence-based breast cancer guidelines that we have available. So I think I'll stop there and I'll stop my sharing and see if I can answer any questions from our Liberian colleagues.
Does anybody have any questions? Feel free to also type your questions in the chat as well.
Yes, thank you so much. Thank you, Dan, for that beautiful presentation. My name is Julius DM4. I'm part of the Liberia team. My question is, we talk about not delaying treatment when it comes to new diagnosis, more especially when there's a need for that patient to be treated immediately to avoid other complications. And most of the cases here in Liberia, we focus on curative, even though all may not be for curative purpose. But I would like to know what could be your recommendation for a patient who has a locally advanced breast cancer, but then in the absence of immunohistochemistry that will determine ER2 positive or HER2 positive. What would be your recommendation for that patient, because we are focusing on curative purpose and not just to treat?
So I think I got most of it, but not the actual question. It sounds like the majority of your patients have locally advanced disease. Is that was the first thing you said? And that in terms of the receptor status, I didn't get the question associated with that.
Yeah, so what would you recommend? Because for status maker, in the absence of that, even though your plan is for curative purpose, but now you are treating in the absence of the clear understanding of the status marker. What will you do? What would be your recommendation for that? Because the target is curative.
Yeah, that's a tough one. Because the ER status helps guide us. But in fact, with some of the guidelines, they actually even address those were what we call the core recommendations in the pathways, but there are even one level below that, the basic resource guidelines. And I believe in those guidelines, they also give you a pathway if you don't have access to hormone receptor status. Again, you only have what you have. It would be nice if you had everything, but you still want to get the treatment going. There may also, we see in other sites like in Haiti, where sometimes it takes a very, very long time to even get the receptor status, and the question comes up whether we proceed with treatment knowing that it may be, a month or two before we get that receptor status back. And that's a kind of a case-by-case discussion. But I would suggest taking a look. It doesn't cost anything. Everybody has access to those nccn.org guidelines. And you can go to the resource stratified guidelines and look under the basic guidelines, where there are guidelines for patients even without receptor status available.
Thank you.
And by the way, that's one thing that we're working on as well in Liberia, to look for opportunities to increasing the availability of certain testing, like for hormone receptor status. So hopefully before too long, it won't be an issue for you. It may be a long time before you have things like HER2 status available, but we're hoping to move in the direction where at least you have basic hormone receptor status available for all your breast cancer patients.
Thank you. Lastly, I listen to you. Here we have challenge when it comes to imaging that will give a clear understanding of the staging, like you mentioned. So can we proceed, like you previously said, if at all you have a patient with maybe M3, T2, M3, and most especially you having to observe that from the clinical perspective. Is it possible that you continue on thinking about curative purpose or just for treatment purpose?
So what you're saying, you have very limited imaging available for your patients with very locally advanced disease. And I think we all recognize that there is a percentage of those patients that may have metastatic disease. And the problem that you're facing actually is a problem that many other countries face. In fact, in the other places where we're involved, places like Haiti, Rwanda, Lesotho, there's very limited CT scanning available, and it's very costly often for the patients. And in those places, what's done is usually a basic chest X-ray, a good exam, abdominal ultrasound to look for liver metastasis if available. We know that and blood work as well. We know that we're missing some patients, but the one thing we don't want to miss the opportunity to treat patients who have potentially curable disease. And the patients who have locally advanced disease, we consider as potentially curable. So we tend to just accept that we don't have as good imaging available. And if it looks, based on the information we have, that the patient has no evidence of metastasis, we'll approach them as potentially curable with a locally advanced treatment pathway rather than a metastatic or palliative treatment path.
Thank you so
That-
much.
Does that make sense?
Yes, it makes sense. Thank you.
Good. All right, are there any other questions? Great, well, Aaron will, I think, provide our emails of all the speakers at the end, and certainly you should feel free to reach out to us at any time if there are questions. And my only regret today is that I couldn't be speaking with you in person, maybe next time. So thank you very much, and we look forward to continuing the conversation.
All right, thank you so